A very good morning to all of you. So my talk today is on decision making in refractive surgery. Now let's begin with the basics. We'll start with the inclusion and the exclusion criteria. Age is an important parameter that one needs to consider. So we essentially wait for refractive stability before the patient can undergo any form of LVC. For a low to a moderate myopia, an age of 18 years would suffice. However, if it's a case of high myopia, I like waiting till about 20 to 21 years because the refractive error takes a little bit longer to stabilize. How to define stability? The refraction should be stable for at least a year, which means that the change in the MRAC should not be more than 0.25 diopters. Now, a lot of these patients will be wearing contact lenses, and the contact lens usage can affect the corneal demography, which is one of the most important preoperative workups that you do in these cases. So the contact lenses should be discontinued for at least 5 days to a week for soft contact lenses and 2 weeks for RGB contact lenses. Corneal ectasia is an absolute contraindication for any form of LVC. See, you already have a weak cornea, and if you perform any form of laser vision correction, the cornea will get weaker further. The only option in these cases after stability of the cornea would be a phakic intraocular lens. Pregnancy and lactation can cause change in the corneal hydration status, because of which there can be fluctuations in the refractive error, and one should wait for systemic comorbidities like diabetes should be well controlled, because an uncontrolled diabetes can interfere with wound healing, especially in surface ablation procedures. Connective tissue disorders were initially considered as an absolute contraindication for refractive surgery. However, if it's a well-controlled disease on immunosuppressions, there's a healthy ocular surface, one can go ahead and perform a laser vision correction. Keloid formation is an important history that one must take. And if there's any history of keloid formation, surface ablation should not be done because it has an increased propensity for scar formation. Another thing about age that you can remember is if the patient is older, for example, nearing 38 or 39, you could perhaps plan for monovision, wherein the dominant eye is undercorrected. So you leave about 1.5 to 2 diopters of myopia, and the non-dominant eye is emmetropic or fully corrected. There are various ways to check for ocular dominance. One of the easiest is to point at a distant object with your finger, close one eye at a time, and see which eye you are using to view the object. Now, the workup begins with a good refraction because that's obviously what you're treating for the patient. A dilated fundus evaluation is very important because in a lot of these myopes, there can be an increased risk of any peripheral retinal degeneration, which has to be treated before the laser vision correction. Ocular adnexa and lid evaluation essentially includes checking for things like dresseritis, any MGB, treating them and making sure that the ocular surface is healthy. You have a good tear film. Corneal tomography and biomechanics has already been dealt with in detail, but I'll be covering it in the subsequent slides and giving you examples of how you select cases. So this is very brief. What is topography? It's essentially a study of the surface of the earth. So we're all aware, in school we used to do this where the plateaus were in yellow, the plains were in green, and the peaks were in red. Cornea topography is similar. It's a study of the surface of the cornea, and you get it as color-coded maps. The predecessors initially were keratometry, so in that only the central 3 mm of the cornea was assessed. But we had no information about the peripheral cornea, the posterior cornea, or the thickness. With further understanding, we've realized that we don't need topography anymore. We need what is called tomography, which is not only the surface, but also the depth. So you also see the posterior cornea, which is very important because early ectasias start more in the posterior corneal surface as compared to the anterior cornea. And you see the thickness, which obviously is also a very important thing while planning the refractive surgery. So this has already been discussed. This is the quad map of the op scan. You essentially have 4 important maps. There's a curvature map. They can be anywhere on the op scan based on how you want them to show as a clinician. But there'll be 1 curvature map. There'll be 2 elevation maps, and there'll be a thickness or a Pacumetry map. And in the center, there's additional data. Now, we'll just deal with some of the abnormal findings or the ectasia indexes on the op scan, wherein if you have any of these, patient should ideally not undergo laser vision correction. So I'll deal with them one at a time. We'll begin with the curvature. The first thing that you look for is an asymmetric bow tie. So this is on the curvature map. You basically see this is a bow tie and it looks skewed or asymmetric. So this is because there is an irregular astigmatism in the case of ectasia. The other thing one looks for is the skew. A skew is nothing but the angle between these radial axes of the superior and the inferior hemimeridien. So if you extend this further, it subtends an angle with the inferior radius, and this angle or skew should not be more than 20 degrees. Another important thing that you look for is the irregularity, which is in the center. So the irregularity in the 3 and the 5 mm zone should not be more than 1.5 and 2.5 diopters. Moving on to the elevation maps. The posterior best fit sphere, which is given here, should not be more than 55 diopters. And the highest point, which is on the elevation maps, the numbers are also given on the maps, should not be more than 50 microns above the BFS. Now, normally the ratio is around 1.2 because the anterior elevation is around 42 and the posterior is around 52. But in case of any ectatic disorder, like I mentioned earlier, the posterior cornea is involved first and the elevation increases. So this ratio of the posterior to the anterior BFS will become more. So anything more than 1.27 is considered as a red flag sign and one needs to avoid laser vision correction. Coming to the Pacumetry or the thickness, it should not be less than 470 micron. And the thinnest reading should not be 30 microns thinner than the central reading. Now, both these thinnest and central readings are available on the tomography, and you can see that the difference should not be at more than 30. Sorry. Now, coming on to tomography or pentacam, there are different red flag signs which we'll go on to discuss. This is what the general quad map looks like. Again, it has the curvature, the elevations in the anterior and the posterior cornea, and the Pacumetry. How the pentacam scores over the op scan is that here the posterior cornea is actually, one actually measures it truly. It's not extrapolated from the anterior cornea like it is in the op scan. So the data here is definitely more specific as compared to what you get on the earlier topography or the op scan. Let's begin with the curvature maps. Here again, the things that you need to look for is that the maximum keratometry should not be more than 47.2, and the asymmetry between the superior and the inferior should not be more than 1.4. So on the left here, this what you see is a pristine cornea. You have a nice with-through astigmatism. You can see that it's steeper vertically as compared to the horizontal meridia, no gross asymmetry, no excessive steepening. On the right, on the other hand, you can see that there's an excessive steepening and a great asymmetry between the superior and the inferior hemimeridien. Moving on to the Pacumetry, on the left you see a normal cornea. On the right, what you see is that the thinnest Pacumetry is inferiorly displaced from the corneal apex, and the difference between the two should be more than 10 microns for it to be a red flag sign. Moving on to the elevation maps, we have both the elevation maps on the anterior and posterior corneal surface. So what you look at is the 3 mm zone. This is not the 3 mm zone, this is the pupil. How you see the 3 mm zone is, you have 0 here and 4 here, this is 2. So 3 mm zone will vary from here till here on the cornea. So in the 3 mm zone, you look for an elevation point, anything more than 12 on the anterior float and anything more than 16 on the posterior float is a red flag sign. So you can see this is a normal cornea, there's no excessive elevation. However, on the right, you have a case of ectasia wherein you can see elevated points on both the anterior and the posterior float. So whenever you see any of these red flag signs, you have to not do any keratorefractive procedure, which means you cannot treat on the cornea. You could do phakic intraocular lens implantations. If it's a borderline tomography, not yet going into the range of keratoconus. If it's a keratoconic eye, obviously you need to treat it accordingly and then give a refractive correction eventually. The Bell brochure again has been discussed. So all you look for at the end is the overall D. This is an overall D of red, which is a cross red flag sign, and the patient should not undergo laser vision correction. Now, assuming you ruled out all the red flag signs, the corneal tomographies are normal. What are the choices that you have at hand? Start with surface ablation. We can do a LASIK, which can either be with a blade or a microkeratome, or with a femtosecond laser. The next option would be a SMILE. This, however, does not work yet for hyperopia. It is not commercially available. Phakic intraocular lenses and combinations with CSL. So I'll begin with a gross overview, and then we see certain case examples. So the main parameters that you have to see here is the spherical equivalent and the tomographic parameters, which mainly include the keratometry and the pachymetry. Now, assuming the patient is of age, has a refractive stability, you ask for history of contact lens wear. The patient is wearing contact lenses, again, you make them stop. I have already discussed the timelines. If no, you go ahead with a corneal tomography. If it's normal, we can do an LVC. If it's abnormal, no laser vision correction. Now, when the corneal tomography is normal, one of the major things that you see is the corneal pachymetry. If it's less than 475 microns on the thinnest corneal pachymetry, the option would be to leave the cornea alone and implant a phakic intraocular lens. Moving on to 475 microns or more. These are rough guidelines. It could be around 470 to 475 and around 490 to 500, but this is what we use. So between 475 to 500 microns, surface ablation would be preferred. If it's more than 500 microns, you see what the residual bed will be. Now, the residual bed is nothing but what you leave behind untouched. So if you're doing a SMILE, you take a cap and then you remove a lenticule. If you're doing a LASIK, you make a flap and then you do an ablation. So after all of this, whatever is left behind, you calculate, and it should be more than 280 to 290 microns. If it's more than it, you go ahead with your refractive procedures. If it's less than 280, again, leave the cornea alone and implant a phakic intraocular lens. Now let's do certain examples wherein one option might be preferred over the other. So this is the corneal curvature. Let me see this video. This is what is called a relatively flat cornea. When you normally discuss corneal curvatures, the average range is around 42 to 46 microns. Now, anything less than 42 is a flatter cornea. Here you can see it's around 40.7, 41. And anything more than 47 is a steeper cornea. Now, flatter corneas on the microkeratome have an increased propensity for what is known as a free flap, which is what you can see here. See, the entire flap has come out in toto. There's no hinge left behind to anchor the flap to the underlying stroma. So in these cases, it would be preferable to either do a femtosecond laser, because the femtolaser is independent of the corneal curvature. It will give you a precise flap nonetheless. If the patient cannot afford it, then maybe you could go for surface ablation because it's a cheaper alternative. But it's better to avoid a microkeratome in such flat corneas. The other extreme is a steep cornea, anything more than 47, 47.5. These are more prone for buttonholes on the microkeratome, and again, the blade should be avoided. An important thing that one should look out for is corneal opacities. Now, corneal opacities, especially dense ones, one should avoid the femtosecond laser, because this laser you'll see now can actually break through the area of the opacity and reach into the epithelium. This is a peripheral one, so we've actually gone ahead with the procedure, but if it's central, you actually cannot continue the procedure. So the important things that you need to do is to carefully first not miss out such opacities. The second is to assess the depth of the scar. If it's a very subtle opacity, which is very superficial, you can always go in for a deeper flap with a femtosecond laser. However, if that's not possible, the other options would be to go for a blade LASIK or to do a surface ablation. Now let's talk about some other extremes. What about a very thin CCT? So you can see here the patient, otherwise the corneal tomographies are perfectly normal, has a stable refractive error, but the cornea is thin. It's around 444 microns. And the Bell procedure is yellow here, essentially because the cornea is very thin. So in such a case, like I've mentioned earlier, because it's less than 475, you will not do any procedure on the cornea and you will plan a phakic intraocular lens. What about high refractive errors? Now, this is the case of around 10.5 diopters spherical equivalent. You can see that the corneas have enough thickness. It's around 528 here and 517 here. So what do we do? Let's discuss, calculate what the residual stromal bed will be. Now, if you're doing a femtosecond LASIK, the flap here is 90 microns. The calculated ablation you can do when you enter in the machine, it's showing 128 microns. So the residual stromal depth that you have here is beyond 280 microns, it's 306. So do you think we can go ahead with the femtosecond LASIK? BRK is not an option here because it's too high an error and there will be a very high risk of regression. Microkeratones could have been done, but the flap would be much thicker. It would be around 110 to 120 microns. So the residual stromal bed would then become lower. There's another important thing that you need to remember. It's called a PTA, which is the percentage of tissue altered, which is nothing but essentially the tissue that you're altering. So it's the flap that you're making, the flap thickness, and the ablation divided by the total corneal thickness. It has to be less than 40%. So coming back to the same case, if you take 90 micron flap with the ablation depth and divided by the corneal thickness, you're actually doing a PTA of more than 40. So in these cases, it is better not to do anything on the cornea and a phakic intraocular lens would be preferred. This is the last case. It's another extreme of a high hyperopia. High hyperopias don't do really well with surface ablation. There's a high risk of regression. Or LASIK and SMILE, like I've said, as of now is not commercially available for high hyperopia. The other problem here is you would want to implant a phakic intraocular lens, but high hyperopes normally are smaller eyes. So very often the anterior chamber depth is not adequate for a phakic intraocular lens implantation. You need a minimum of 2.8. So you can see here the patient has a high hyperopia, but the anterior chamber is just not large enough to do a phakic IOL. So what we've done here is a clear lens extraction, but you can see that the IOL power here is around 39 in one eye and 49 in the other. The maximum commercially available lenses that you get, especially with the Thickness, which is the maximum, would be around 40 diopters. So after doing that, the right eye was almost emmetropic, but the left eye still had a large amount of refractive error left. The other options in this would be to do a piggyback IOL, or we use the sulcoflex. So this is a lens which sits on top of another lens in the sulcus. So this can be used in highly hyperopic eyes. It's a single piece lens. This has a 6.5 millimeter optic. It has large undulating haptics, which let it fit very snugly without support. There's a posterior angulation at this junction. That's essentially done so this lens is slightly forward and is not in contact with the lens behind. So there's no interlenticular opacity. And this is hydrophilic as against the hydrophobic lens that you will have implanted after the clear lens exchange. The IOL power calculation here is very easy. You have the Holiday and the Gales. Holiday is for 1 for a myopic correction, which means if you have one diopter of myopia on refraction, you give a 1 diopter sulcoflex. Hyperopic is the Gales formula, which is roughly around 1.5 times. So I think I've finished my 15 minutes. So I just like to conclude that with a thorough clinical examination and a very good understanding of the corneal tomography, you could go ahead with absolutely no issues. There is a careful case selection involved in certain extreme cases, like the ones I've discussed, wherein one procedure may be preferred over the other, even though the corneal tomography looks normal. Thank you.
Thank you, Gitansha. You really summarized the whole thing very well. And given the adequate knowledge of red flags, so what would be your option for patient who's not fit for refractive surgery, even say, let's say a myope also, but an AC depth is less than 2.8? You've already covered it in a hyperope, but a myope -5, -6, and AC depth is also not so good.
So basically, I would go till about 2.7. If the AC depth is up to about 2.7, the patient could undergo a phakic intraocular lens implantation. I am not a believer of a clear lens extraction in a high myope, especially before the age of 40, where the PVD has not been completely induced and the risk of retinal detachment is much greater. There have been multiple Cochrane reviews which show that the risk of RD following phakic IOL in multiple papers ranges from around 2% to about as high as 8%. So I would just tell the patient not to undergo laser vision correction, just wear contact lenses or spectacles, whatever.
That's right. That's right. So that's what we'd like to take. Thank you. There was a question in the chat box where the gentleman has asked about if you only could summarize what is Berlin Ambrosio display.
Okay, I'll just show you the
Yeah.
presentation so it will be easier.
I think we have 5 minutes, so we can do it in that. Yeah.
Is it visible? I can't see it.
Yes, the screen is visible.
Yeah, I'm somehow not able to see my own screen. Just a moment. Yeah.
Yes.
Yeah, I'm just opening the.
Yeah, this slide is already there.
Oh yeah, wonderful. If you don't full screen. So
Right.
the Berlin Ambrosio is nothing but I'm sorry, I was in another session, so I missed Pooja's talk. I don't know how much he's covered, so I just
she didn't cover about bad. So
okay.
Maybe you can.
So I'll just start. So essentially, there's something known as a best fit sphere, which is a combination of all the points of the cornea of a particular diameter. We normally take around 8 millimeters, right? Why we take 8 is if you take a much larger one, you'll end up including the peripheral cornea, and the best fit sphere will become flatter. If you take a shorter BFS, you'll end up taking more of the central cornea, which is steeper, and the best fit sphere will become steeper. So the best fit sphere is nothing but a total average of 8 millimeters. So it's like taking the sea level. You imagine the sea, you imagine a mountain, and you imagine a pit. The best fit sphere, for example, if it's a sea, anything lower than that, or the pit will show as a depression, and anything higher than that, like a mountain, will show as an elevation. So now you have a BFS of whatever value on the cornea. All points steeper than that will be an elevation, and all points which are not steeper than that will be depressions. So we need to look for steeper points because that's what happens in keratoconus or ectasias. The cornea undergoes a steepening, right? So I've already shown this comes on the float or the elevation maps. So I've already discussed that you have elevation maps of both the anterior and the posterior surface. So this is what you have on the quad map as well. These are the elevation maps. Then what you do is you exclude 3 millimeters from the center of the cornea. So now you're calculating a new BFS wherein you've excluded the central 3 millimeters, which are obviously the steepest 3 millimeters. So what you're left behind with is a slightly flatter BFS. So what will happen here is now, if the cornea is still normal and you're still flattening the BFS, there will not be extra areas of elevation in the central 3 millimeter zone. However, if it's a case of keratoconus, which has an increased elevation, and you've removed the central 3 millimeters, you'll be able to see these difference areas in the center. So what you get at the end is the difference map. So this is the regular BFS with 8 millimeter diameter. Then you exclude 3 millimeters of the central cornea, excluding the more steep points, getting a flatter BFS, because of which these steeper points will now show more. And what is shown here is the difference map. So you look at the difference. Green means it's normal. There's nothing abnormal. This is slightly borderline, and this is a red flag sign. So difference of more than 7 microns here, like here, is a major red flag sign. And on the posterior cornea, if the difference is more than 16 microns. So this is one of the major parts. This is on the elevation. This is the same thing which comes here as the front and the back. Now these three are to do with the thickness. Okay. So thickness you can have as CTSP and as the PTI. So this is nothing but the corneal thickness in all the 4 hemimeridia, which you can see here. So it takes superior, inferior, nasal and temporal, and it shows how the cornea continues to progress in terms of thickness in relation to the center. So this is the thickness spatial profile, which shows that, okay, in the center, it started here at 500, and then it's as you're going down to the 2 millimeter, the 4 millimeter, the thickness is continuing to change. The percentage of thickness increase is similar, but it's the same thing calculated as a percentage. So again, this is plotted by the machine as such. So you have to see both these curves and they have to fall within the 2 standard deviations. This is normal. So you're seeing that the way the thickness profile is going on all 4 meridii from center to outwards in terms of the thickness and the percentage are normal. However, here you see that there is a variation. This is an abnormality. These are seen as the Pacumetry. The thickness changes and this is the axial displacement. Like I mentioned before, the thinnest point axially displaces inferiorly in a keratoconic eye. So all 5 of these are then put together by the machine itself. You don't need
Apologizing to all the doctors to please sum it up because it's about 12 a.m., 12 p.m. and we are
Yes,
about to
yes,
start
she's
the next
finished. She's
session.
finished.
So this is the overall D, and this is the other thing that you need to see on the Bell and Ambrose domain. That's about it.
Thank you, Gitansha. So in nutshell, the advantage of bad is whenever you have a suspicious looking cornea, when you're not very sure of whether it's a keratoconus or not, you like to use bad so that it highlights that particular